initial trial was a trial that was exploring in the third and fourth line setting on non-small cell lung cancer the value of sorafenib as compared to placebo. High expectations were placed in that trial. Unfortunately, the primary endpoint, which was improvement of overall survival, was not met. Interestingly enough, progression-free survival and objective response was increased in the sorafenib arm, but that did not translate in an increase of overall survival. An exploratory analysis performed by Professor Tony Mock, based on a subset of around 20–25% of patients for which plasma was available, allowed to do an analysis on the presence of EGFR mutation in the plasma of those patients. Interestingly enough, in this exploratory analysis, that was not a predefined endpoint of the trial, it was demonstrated that sorafenib improved overall, had a positive interaction in terms of improvement of overall survival when EGFR mutant patients were exposed to sorafenib. So today at the Presidential Symposium, we heard the first ever reported randomized prospective data in ALK positive patients where crizotinib, an orally available compound, was tested in front of second-line chemotherapy, either pemetrexed or docetaxel. This phase 3 trial, called Profile 107, was presented by Dr. Ali Shaw on behalf of her co-investigators. To summarize the trial, clearly, crizotinib is a game changer for the survival of ALK-positive patients. It met its primary endpoint, which was improvement of progression-free survival. PFS was improved by 4.7 months in the crizotinib arm as compared to the chemotherapy arm. Objective response was tripled. So this was obtained with a drug that had mild side effect profile. Overall survival was not a primary endpoint. The data presented on overall survival are immature. Only 40% of the events have happened. That is important to pinpoint. And these overall survival curves show no difference between crizotinib and chemotherapy. So what is the explanation for this lack of difference? As I say, number one, immaturity of the data. Not all events have happened. Second, most of the patients on crizotinib, 46% of them, are still on crizotinib, so we need to wait to see what happens. And third is crossover. For ethical reasons, patients with ALK translocation that got randomized to chemotherapy were allowed, in case of progressive disease, to cross over to the crizotinib arm. So you have 87% of the patients who experienced progressive disease in chemotherapy that went in the crizotinib arm. I think that explains why there is no overall survival difference. However, it is very important to look at those curves of overall survival in the second line setting. The median overall survival for both arms, chemo or crizotinib patients with ALK translocation, was 21 months and 22 months. This is unheard of in the history of lung cancer. Classically, median overall survivals in lung cancer, non-small cell lung cancer, are in the range of 6 to 9 months. This compound is now available in the US for more than a year. It has been FDA approved in August of last year. It is not yet approved by the regulatory authorities in Europe. So we have a lagging time that is of more than 12 months. However, I think crizotinib is a really amazing drug, and it will probably bring more than therapy and success for ALK translocated patients in non-small cell lung cancer. Why is this? In fact, ALK abnormalities exist beyond lung cancer. There are such abnormalities in inflammatory breast cancer in terms of ALK amplification, in neuroblastoma. There are abnormalities also in some rare forms of sarcomas. And therefore, inhibition of ALK will probably be something of benefit beyond lung cancer. Second, crizotinib mechanism of action is not only to inhibit ALK, it can also inhibit ROS, it can also inhibit RET, it can also inhibit RON. So the potential of this drug is quite broad and very interesting for the benefit of cancer patients.